All right, so we'll get started. It's hard to give a lecture in 15, 20 minutes or whatever we've been asked to do, and so I got a lot of requests to talk about acoustic neurosurgery, and so I thought if I was going to be able to do that, I'd have to do it in multiple parts, and so I thought the first part, the natural place to start, would talk about hearing in general, and so this may be a little bit of a hodgepodge of things about hearing. And I'll talk about acoustic neuromas maybe at a future session, but I'll start with some basics on this. I thought I would start, though, with this sort of little personal side of this story, just tell you why I'm interested in this topic. This is my family, actually. This is the Barnett side of my family. This is my grandfather, Hoyt, my grandmother, Millie. Both of them had prelingual deafness, meaning that they did not have any hearing at the time of acquisition of language, and so it comes with a sort of obligate speech impairment. And as the story goes, my grandfather was born deaf, no known cause, was never determined, and my grandmother lost hearing as a toddler, presumably from some sort of infection. And my grandfather's family, they were poor farmers from Belton, Texas, and they made a difficult decision to send their son to live here at the Texas School for the Deaf when he was a little boy. Turns out Texas School for the Deaf, it's in Austin. It's the oldest public school in the state of Texas. And in a sort of a similar way, my grandmother's family decided to move their entire family from Junction, Texas, which is in the sort of the hill country area, all to Austin so that she could go to school there. So they went to school there. They learned sign language. They interacted with other deaf children. And as it turns out, that school has a lot more in common with regular schools than it doesn't. And so my grandfather was on the football team. My grandmother was the cheerleader. And so they met and fell in love and ended up getting married. They both had jobs. My grandfather learned the printing trade in school. And so he worked in the newspaper, sort of setting the type for advertisements, and my grandmother learned data entry, and so she learned how to use the punch cards that data was entered on sort of the original IBM computers, and so she worked for banks for her career. They had a family, and so these are their three sons. My dad here is the one in the middle. That's my dad. This is my Uncle Larry. It's my Uncle Charles. As you can imagine, they had an unusual childhood. They all learned how to learn sign language before they could talk. So they remained bilingual their whole life, and they had sort of unusual responsibilities as young children. So they served as translators for when they're shopping or for the outside world. They answered the telephone, things like that. They had to spend a lot of time with their extended family, their grandparents, so that they could learn spoken language as well. They all ended up going into the military. This is my dad. This is my Uncle Charles, my Uncle Larry. They all used that as a means of paying for college. The fact that they had military service was very something my grandfather was super proud of. He was a patriotic guy and something he was excluded from. And so they all went into graduate college. My dad ended up getting a PhD in physical chemistry. My Uncle Charles got a degree in music and was a professional organist, interestingly enough. And my my Uncle Larry used his sign language skills to become a professional interpreter. Also interesting, all three boys ended up working at the Texas School for the Deaf at different times. They were basically they called them house. I forget the name of the term actually, but they all like served to sort of handle the boys that boarded there. And so I mentioned this only because it's number one, it's one of the reasons why I'm interested in hearing loss. I also think it's interesting that my great grandparents, their recognition of the importance of education to send their children to the Texas School for the Deaf, that trickled down to my dad and his brothers and into my generation as well. So I'm sort of thankful for that. And also, I think that the interesting thing about hearing loss is it is the only neurologic deficit that I'm aware of that has it's associated with its own cultural identity. And the deaf community is a sort of a robust, vibrant community. They have their own schools, they have their own churches, they even have their own universities. And so I realized that this type of deafness is not the type of hearing loss that neurosurgeons deal with typically, but it does give me some perspective on all that. So what I'm going to talk about is a little bit about normal hearing, a little bit about how you assess hearing, and then I'm going to talk about mechanisms of hearing loss specifically for acoustic neuroma, and then hearing rehabilitation options also specifically with acoustic neuroma in mind. So in the upper left, we have a cartoon of the ear. Sound waves are collected by the pinna, transmitted through air conduction down the external auditory canal to the tympanic membrane. The waves are then converted into bone conduction, and they're amplified through the ossicles, malleus, incus, and stapes. The stapes inserts on the oval window of the cochlea, and those waves are now transmitted to the fluid, the perilymph of the cochlea. And then the cochlea converts this mechanical stimulation into an electrical one in the organ of Corti. So this is a schematic of the cochlea. Cochlea is tonotopically arranged and has sensory epithelium with hair cells. The different portions of the organ of Corti have different stiffnesses, and they respond to different frequencies. As they are deflected by these sound waves, they generate action potentials, and then those action potentials travel through the cochlear nerve out the medullus or cochlear aperture. Here they travel to the cochlear nucleus, cross over the superior olivary complex, they ascend through the lateral lemniscus to the inferior colliculus, up to the medial geniculate of the body, and then on to the auditory cortex. So how do you test hearing? So this is the classic bedside testing that I think we all learn in medical school. Most of us probably never done again, but it does have a small area of utility for us, and so I'll just give it to you real quick. The Rene test, the one on the left, compares level of air conduction and bone conduction in the same ear. In a normal ear, the air conduction is greater than bone conduction, and so it takes approximately 30 decibel conductive loss to flip that response, and so you can tell if somebody has significant conductive loss with the Rene test. That is generally not something that neurosurgeons are that interested in. The Weber test will lateralize to the ear with conductive loss if sensory hearing is equal. The way to take advantage of that for us is that to test a patient post-operatively to see if hearing preservation surgery for an acoustic neuroma was successful. So this takes advantage of the fact that the approach, either a middle fossa or a retrosigmoid, comes with an obligate temporary conductive loss just from the drilling, the fluids, and et cetera. So a Weber test will localize to the operative side, the side with conductive loss, if hearing preservation has been successful, if the sensory neural hearing is still present on that side. And it will localize to the opposite ear if the sensory neural hearing has been lost. So if you need to test somebody right after surgery for middle fossa acoustic to see if you think that they have preserved or lost their hearing, that is the best single test to do at the bedside. And then next thing is audiograms. So really this is something that otologists use, but it is useful to understand how to look at one if you are a neurosurgeon and you operate in the CP angle or see patients that present in this way. So the first thing to look at is this sort of graph on the left. It's the pure tone audiogram. The x-axis is frequency measured in decibels, so low frequency sounds all the way up to high frequency sounds. The y-axis is inverted just by convention and is in decibels, so from very low volume sounds up to very loud, high volume sounds. And then each ear is then graphed independently, and there is almost always a legend to tell you what exactly is being graphed. So in this case, red circle is right ear air conduction, and you can see that, for example, at 250 hertz, it only took 15 decibels for this patient to pick up that sound, and they graph it at each frequency, and they graph each ear separately. And so you can see that maybe there's a 5 decibel difference between the right ear and the left ear in this patient. and then they average those decibels, and so the pure tone average for the right ear is 13 this patient, 18 for the left ear. Just point out this gray shaded area. This is sometimes called the speech banana. That is the range at which normal conversational speech happens. And so if your hearing is at this level or better, you're likely to be able to communicate normally as far as the pure tones go. And then the other part that's worth looking at for us is the speech recognition score. And so there's two parts of that, I guess. One is the speech reception threshold, which is listed here, which is the lowest volume at which any speech can be discerned. In this case, 15 decibels on the right, 30 on the left. And then they get to a relatively comfortable sort of loud volume, so 80 decibels for each ear, and they test the patient on work and see if they see how many they get correct, and they also mask the other ear so that the patient can't cheat by picking it up on the other side. And this patient got 100% of the words correct on both ears. And that leads to this, which is the classification schemes. There's really no need to memorize these for us, but it is worth knowing sort of what the cutoff is for what is generally considered to be non-serviceable hearing. So if the patient is worse than 50 decibel pure tone average, which puts them in sort of this category here, or this category here, and they understand less than 50% of the words given to them, that puts them in the so-called non-serviceable category. So 3 or worse on Gardner-Robertson, or in the class D hearing in this other scale. And so that's usually the cutoff for being a candidate for hearing preservation surgery. So if it's below that, it's not worth considering. And also that person not going to be able to use that ear for normal communication. As it turns out, this patient had a small acoustic neuroma, which led to this very mild deficit. And so this is what a audiogram might look like in a large acoustic neuroma. So you got same thing. So right ear, you can see that it's okay at lower frequencies, but at higher frequencies it's much worse. So below level of the sort of the speech banana. And then the left ear is essentially normal. It slopes a little bit on the upper frequencies, which is common for older people. So you could just predict that this person might be older than the last patient, had almost flat audiogram. A little bit of high frequencies sensory neural hearing loss is normal in older adults. If you look at the pure tone average, it was 48, so just near the cutoff for non-serviceable on the right ear, and 15, which is normal for the left ear. Interestingly, the speech recognition score was 0 in this ear. You might, if you looked at this, say that maybe they would get a few words correct based on the way this pure tone audiogram looks, but they actually got 0 correct. Left ear was normal at 100%, and that feature is something that is consistent with what's called retrocochlear pathology. So when you have a lesion of the cochlear nerve or further along the pathway, it is often true that the speech discrimination is worse than you might expect based on the pure tone average. And so that would fit with an acoustic neuroma pathology. The other thing that they tested for here, which didn't show it, but is something that's worth knowing also, is something called rollover. So they tested this patient at a higher volume and a slightly lower volume. And so it turns out that some patients that have retrocochlear pathology have this rollover phenomenon where they do better at lower volumes, actually. So the more you increase the volume, the lower their speech recognition score goes. Next, this is an example of a conductive loss, just so you know what the difference is. So again, we have the right ear here in red. Looks more or less normal. Pure tone is 10. Speech recognition score is 100%. On the left, you have a significant gap between the right and left ears. Pure tone is 32. But I would point out that you can see these extra charting here on the legend. So with a bone conduction with a masking placed, you can see that the patient did significantly better. So much closer to the right ear. You can also see that the tympanometry is flat in this left ear, suggesting that there's either fluid or some fixation of the left eardrum. And so this patient has a conductive loss based on these findings. Next up is what an audiogram would look like in a patient with NF2. You can see profound bilateral sensorineural hearing loss. Pure tones were super high, and you could not evaluate any speech recognition for either ear, so profound bilateral deafness. And I'll use this one just to point out one other extra section of the audiogram that, again, is more for otologists than us, but it's pretty fascinating. It's this acoustic reflex. This is sort of a diagram what the acoustic reflex looks like, but it measures the contraction of the stapedius muscle in response to an acoustic stimulus. And so you can think of this as the hearing equivalent of the consensual pupillary light reflex. So a loud acoustic stimulus, usually greater than 85 decibels, will activate this reflex, and it happens in the superior olivary complex, and that has projections to the bilateral facial nerves, which activates the stapedius muscle. So the stapedius muscle stiffens the ossicular chain by pulling back on the stapes, which dampens the vibrations, pulls the stapes away from the oval window, and this serves to protect the cochlea from damage due to excess stimulation. And so you can imagine a reflex that is as complicated as that, which involves brainstem, bilateral facial nerves, that just like the pupillary light reflex, you can, if you do it both sides and do all the tests, you can localize pathology by what the responses are. As it turns out, much like checking pupillary light reflexes, much of this has been supplanted with imaging. So it's much easier to localize subtle pathology with CT and MRI than it is with this complex test, but it is still used in certain cases. I understand that the otologists still use it to distinguish between superior semicircular canal dehiscence and otosclerosis. So it still has utility, not necessarily for neurosurgeons, but it is an interesting test. So next up is the auditory brainstem response, or brainstem auditory evoked potential. So in contrast to audiogram, this does not require a patient's participation. Some form of this is used for newborn hearing screening. It also can be used in awake patients as part of evaluation for certain neurologic conditions. And the most frequent use for this for neurosurgeons is using it as intraoperative monitoring during surgery for either CP angle surgery or hearing preservation surgery for acoustic neuromas. The way it works is you have sort of an earbud in the ear. There's a series of tones or clicks in the case of the monitoring we use that travels through the auditory pathway, and that generates a very characteristic set of waves if you do surface recording. All of this has been sorted out very clearly in animals. This is sort of extrapolated where these waves come from in humans, and there's a little bit of controversy about that, but the wave 5 is the one that is the most robust and most closely followed during surgery. It's definitely occurs in the midbrain. Some people believe it represents the inferior colliculus. Others think maybe it's the nucleus of the lateral lemniscus. But in any case, it is a very reproducible, very consistent pattern, and can be monitored during surgery for an anesthetized patient. Any change in amplitude or latency can be relayed to the surgeon to let them know there's been a change. The important things to note about this is that it takes approximately 2,000 cycles of these clicks and sampling to generate an interpretable waveform. And so what that means is the acquisition time for a waveform is over a minute. So it's usually considered to be 1 or 2 minutes. So if something, the neurophysiologist tells you that you've had a change in the latency of wave 5, that means that something you did 2 minutes ago is what caused that. So the fact that it's not real-time monitoring is something you have to be aware of when you are using it during surgery. There is another way to do this called direct cochlear nerve monitoring. You have to place an electrode near the cochlear nerve during the dissection, and it gives you much more real-time data, but similar information to the neurophysiologist. But it is a little bit cumbersome. It's an expensive probe, and it's kind of in the way oftentimes during surgery. But it is an option if you really feel strongly about having more real-time data. The other question that comes up is, what is the predictive value of this statistically for acoustic neuroma surgery? There's not very good data for that out there. There's mostly sort of case series and things like that, but it is generally agreed that stability of the ABR is predictive of hearing preservation surgery during surgery, and that loss of it, if there's no technical problems, is very suggestive that you have lost hearing during surgery, and that has been my experience as well. All right, so we're going to switch gears for a second and talk about mechanisms of hearing loss for acoustic neuromas. So I think that cochlear nerve compression is sort of the obvious cause of hearing loss, but it turns out that it is more complicated than that, and that would become obvious to you if you see a number of these patients. That occasionally you'll see a patient with a huge tumor with totally normal hearing, and in contrast you'll see a patient with a very, very small tumor with terrible hearing. And so something doesn't quite add up. So there obviously is more than just cochlear nerve compression going on. This is a paper from a few years ago, actually from a recent guest of ours, and he looked at intratumoral hemorrhage and fibrosis as a possible contributing factor. And they looked at, I believe, 240 cases, and found that while size definitely correlated with preoperative hearing loss, the finding of hemorrhage in greater than 25% of the specimen, or fibrosis, as seen here, was strongly correlated with preoperative hearing loss. The thought being that as any intratumoral hemorrhage or fibrosis would cause some inflammatory response, and that would have a direct impact on the cochlear nerve adjacent to the tumor. Another interesting thought is that cochlear aperture obstruction or medullus obstruction is an important factor. So this is just an example of a patient with NF2, and you can see a tiny acoustic with complete obstruction of the medullus here, and then a slightly larger tumor with you can see CSF intact up to the fundus of the IC. And as you might guess, this ear on the right had normal hearing and complete loss of hearing on the left. This is also part of the idea is that having obstruction of the cochlear aperture increases intracochlear protein. You can see proteinaceous fluid in the cochlea here bilaterally on this flare sequence. And so this is sort of a thought that may be contributing as well. Other proposed causes of hearing loss beyond these two and cochlear nerve compression are intralabyrinthine hemorrhage or endolymphatic hydrops, or increased pressure within the cochlea. So if you have a patient that had surgery and for hearing preservation, or for just acoustic neuroma that you weren't intending to save hearing, but they now are unilaterally deaf, what can be done about that? There are a couple things, and go through them briefly. So this is called a CROS hearing aid. And so this has been around a long time. It's the least expensive thing that you could try. And it's also easiest to try without sort of committing to it. You can sort of do a test drive of this. And so what you do is you wear basically a hearing aid on both ears. On the poor ear side, it's just a receiver, and it transmits the sound to the good ear, sort of via a Bluetooth concept, and delivers sound through the better ear. And a similar version is called a bicross, in which that sound is amplified when it gets to the better ear, and that's when patients have hearing loss in that other ear. Like I said, the advantage of that, it's very easy to try, and if someone likes it, they can sort of decide that before they commit to it. The disadvantage of it is it amplifies background noises a lot. It's got this social stigma of wearing bilateral hearing aids, so patients don't like it in general. And then the biggest issue, I think, is that you occlude the better hearing ear with this hearing aid, and so patients don't like it for that reason as well. Next is a bone-anchored hearing aid, and so it takes advantage of the fact that bone is a very efficient conductor of hearing, and so you basically have this bone-anchored hearing aid on the bad ear, and it sends sound through the calvarium, through the skull, to the good ear. There's more than one way to do it. You can put in a sort of a percutaneous abutment, which is sort of the most powerful way to do it. You can also put in a subcutaneous system. There's a magnet and a transducer that is effective, but it's not as powerful as the percutaneous system. And then our very own Dr. Coots did this study, which is a little bit out of our, out of neurosurgeon's element for this, but it does bring up a couple interesting points that I wanted to make, and hopefully I'll illustrate them here. He looked at 126 patients that had unilateral deafness for any cause that had an implanted BAHA, and compared that with 126 patients that had deafness after a translab approach for acoustic neuroma. And they had this sort of questionnaire where visual analog style questionnaire where they give a question and they decide, how easy it is for them to do that. So you're talking with one person in a quiet room. Can you follow what the other person says? No, or really, really easy for me. So if you look at how these BAHA users did, so talking with one person while there's other voices, talking with 5 in a noisy air environment, this is one of the biggest complaints that patients have that have unilateral deafness. So if they are in a crowded environment and they're trying to have a conversation, it is very difficult for them to isolate one person's voice amongst others. And so you can see that this is patients who were using their BAHA had a significant advantage in this. And so one of the biggest complaints that patients have with this can be offset by the use of a BAHA. The other biggest complaint that patients have unilateral deafness report is not being able to localize sound. And so BAHA is helpful for that, but not nearly as good as it is for sort of their speech interpretation. So they can localize whether somebody's on the right or left. But there are some disadvantages. They can't judge the distance at which sounds are coming from, and it's not exactly always where it's expected. So it doesn't necessarily correct this. And I think that makes sense because this is not binaural hearing, it's pseudo-binaural hearing. And then finally, when you look at the different qualities of sounds, this is where the BAHA is not particularly good. So like listening to music or something like that, the BAHA sounds very artificial to patients. And so when a patient is listening to music or something like that, or maybe talking to a loved one, they'd probably rather not use their BAHA because it has a sort of artificial quality to it. So the summary of Dr. Coots' study here was that the BAHA improves speech intelligibility in patients with unilateral deafness, but sound localization is still a problem, and but it is better than nothing. Interestingly, though, while many studies have shown that BAHA is beneficial to patients with unilateral deafness, most patients choose not to have it. So only 25% of patients that went through the sort of the assessment stage and ended up opting for to have one. So while it's an option, most patients choose not to use it. All right, so a couple more things. Cochlear implants. So cochlear implant is an amazing device that can be used, and it's really approved specifically for like elderly patients that have bilateral hearing loss, and it can take somebody that is very poor hearing and allow them to talk on the telephone. It really is amazing how well this works. And there's been some interest in using it in NF2 patients that have gone deaf from acoustic neuromas bilaterally. The thoughts are that if you have tumor present but poor hearing, smaller tumor present with poor hearing, or that you were not able to preserve hearing after surgery, but you know that the cochlear nerve is intact, it might be a candidate for cochlear implant. The magnet that is in there for attaching the device has to be removed because the NF2 patients require a lot of imaging, so they have to use other means to secure the device on their behind their ear. And so Mayo Group did a study in which they looked at 10 patients with NF2. They implanted 5 of them after surgical resection of tumor, 4 after radiation, and 1 with no treatment at all. The mean follow-up was 42 months, and interestingly, 9 of the patients developed sound awareness. 6 were able to have open set speech, meaning their word recognition score was better than 0. And probably most importantly is that 7 of the patients that had implanted devices used it daily, which is probably the best measure of how effective it is. The patients that did worse were patients that had longer time of deafness, ossification of the cochlea on imaging, or unfavorable promontory stimulation testing. Promontory stimulation testing is the cochlear promontory is part of the cochlea that can be seen through the ear canal, through the drum. And so there's a way to stimulate that directly to see if the cochlear nerve is intact. And so it's a test that can be used if you really are not sure if the cochlear nerve is intact. You can ask the otologist to do promontory stimulation testing and to see if that's present or not. The other thing is if they had useful hearing on the other side, they're very unlikely to use their device because it's not as good as the normal hearing ear on the other side. It turns out that how you manage the tumor, the approach of surgery choice, or tumor size did not seem to make a difference. And there's a similar study from NYU that published very similar results. Another study showed that 37 patients with failed hearing preservation surgery for NF2 patients, that 68% were able to achieve some open set speech recognition, so their word recognition score went from 0 to something better than 0. And again, promontory stimulation testing may be helpful to identify the right patients. And then next up is the auditory brainstem implant, which a few of you've seen. We've done, I don't know, 12 or 15 of those here at UT Southwestern. This was developed by Dr. House at the House Ear Clinic in the late 70s. Their initial device was just 2 ball electrodes placed near the cochlear nucleus. Apparently, this patient that had the first device used it for 30 plus years and was a heavy daily user of it. There are 2 companies make a device for this now. It is approved for patients with NF2 that are older than 12 years old. You place it at the level of the cochlear nucleus after the tumor's been removed. It's been found to improve communication and sound awareness, helps with lip reading for many of these patients. Although, in our experience, open set word recognition is quite rare. This is what the device looks like. It's this tiny paddle lead. This is what it looks like on an MRI. It's placed right there. When you place it, you have there's sort of a whole team of audiologists. Some are in charge of stimulating across these different electrodes, and then another team is monitoring the ABRs that you get on that basis, and we try and adjust the electrode so that patient gets stimulation across as many possible electrodes as possible. Not surprisingly, the cochlear nucleus is tonotopically organized, and so after this is placed and the patient has good connection with numerous points of these electrodes, the device can be programmed to give them sort of a range of sound awareness after they're they can sort of work with the device. You also have to monitor cochlear or cranial nerve 9 during the placement, because you can get cross stimulation, and if you get cross stimulation, the patient gets this sort of throat tightness and things like that. So you really have to make sure that you're getting only cochlear stimulation, not cranial nerve 9 stimulation at the time of the placement. So this is some of the data. I'm going to skip this one actually and go to this one. So this is some of the published results on ABI placement in NF2. You can see in their patient, virtually all of them got some sound awareness, and then probably almost a half got some speech recognition. That's much better than than our experience has been, and in fact, it's been difficult for other centers to reproduce some of this European data, but nonetheless, there are many patients that we have implanted that use it frequently because they feel that it is helpful for them. Skip that, and then this brings us to sort of just a dilemma here. So you have this patient with NF2 has this giant right-sided acoustic neuroma, a much smaller left-sided acoustic neuroma. But because NF2 is a very cruel disease, you can see that the right ear, in red here, is the much better hearing ear. So the giant acoustic has the better hearing ear, the smaller acoustic, much worse. And so why is that? It may be back to our mechanisms of hearing loss issues, that and the left-sided tumor, the fundus is completely impacted, and there's complete obstruction of the medullus on the left. And then you can see a fundal cap of CSF on the right side. Maybe there's some intact CSF flow here, which is protecting the nerve on the right side. So what do? This right-sided tumor's got to come out. Do you put in an ABI on the right side, or do you put a cochlear implant in on the left side? What we opted to do was put in a cochlear implant on the left side. We took the tumor out, cochlear implant on the left side, and this is sort of what happened with this patient over time. So the AZ Bio is sort of a standardized battery of word tests for assessing a cochlear implant patient. And so before surgery, they got 0% word discrimination. At 4 months, they were up to 41%. And 10 months post-activation, they're up to 74% word recognition score. So they really got amazing results from this, up to serviceable hearing after placement of this. And it's important to note that this is not just sort of the natural history of what happens when you place a cochlear implant. This requires tremendous effort and motivation on the patient's part to practice using it, to use it frequently, and sort of working with an audiologist for programming and testing. So it takes apparently at least 40 hours of sort of therapy and work with a cochlear implant to really get a satisfactory result, and that's what was required in this patient. All right, so sort of the final topic is beyond devices, what else can we do for hearing preservation? And so there is one pharmacologic option available, and that's Avastin or bevacizumab. Mechanism of action is not known. May shrink the tumor just a little bit, may decrease edema or inflammation, and may also restore the protein homeostasis. Like we said, that some mechanisms may be from intracochlear protein elevations. skip the tumor growth thing. This is a more fascinating slide. So this is what happens with hearing in 31 patients. So this is sort of a graph of each patient, and this is their word recognition score on the left. And you can see that after initiation of Avastin therapy, there's several patients who went like sort of these patients who went from non-serviceable hearing, very poor hearing, all the way up to very useful hearing for them. And so 57% of patients had a hearing response. There were a number of patients that had very poor hearing that had significant improvement. As some of you may know, Avastin has lots of side effects, and many of these patients require drug holidays. In most of the cases, the hearing would decline during drug holidays, and when they were reinitiated on therapy, their hearing would improve. It's certainly not a totally durable effect, but it is definitely a way of extending someone's hearing if they don't need urgent surgery. So definitely something to consider. Send your patients to neuro-oncologists for consideration of Avastin if they have an acoustic, and you want to try and preserve the hearing as long as possible. Again, this is just a list of some of the adverse events that happen with Avastin therapy, and the reason they need to take holidays for some reason. And so just to wrap up, hearing loss is not simply cochlear nerve compression. It's more complex than that. Preserving the nerve is superior to rehabilitating the nerve. BAHA is superior to a CROS hearing aid for unilateral hearing loss, although not very well utilized. If you have an intact nerve, cochlear implant is the best way to go for as compared to an auditory brainstem implant, although it is the only option for patients without intact nerves. And Avastin has promising results for hearing preservation.
Sam, I have a quick question. Can you hear me?
Yeah, I can.
So for an NF2 patient, as it stands, you'd recommend a cochlear implant over a brainstem implant for hearing extension or maximizing hearing?
Yeah, I mean, I think that is sort of the evolving model, is that if they have a tumor that it doesn't need to come out right away, and they have lost all their hearing. So it's a patient that's got bilateral profound sensory neural hearing loss, but doesn't need a tumor resection at the moment. Avastin or cochlear implant are both options at that point, but a cochlear implant is far superior to an auditory brainstem implant. And then the other model too is like if you do resect the tumor, every effort should be made to preserve the cochlear nerve if possible, if the tumor's amenable to that. And so that may, in some rare cases, the patient can have surgery, like the Mayo group presented that data where they then after resection, but they preserve the cochlear nerve.